Auzubillahiminashaitanirrajim. Bismillahirrahmanirrahim. So today we're going to talk about the herpes in pregnancy for the MRCOG-2 exam, the points. Okay, so it's very simple if you look at it from the exam point of view. Okay, the guidelines have changed just one bit. One thing has changed. I'll tell you guys at the end. So herpes, first you should, ask yourself whether it's a primary infection they're talking about or a recurrent. The second thing you have to see in the question is that whether it is occurring before 28 weeks, whether they have mentioned first trimester, second trimester, or it is happening after 28 weeks, whether they're specifically going to mention 6 weeks before delivery, 4 weeks before delivery, anything after 28 weeks. So classify like this and classify like this in your mind, okay? So let's do the easier one first. If it's recurrent, if they have mentioned that it's recurrent, and first of all, you have to be very confident. With recurrent, you have to be very confident, and with full confidence, you have to say that I'm going to deliver this patient vaginally. And with the same confidence, you're going to say that the reason is because the risk of neonatal herpes is only 0 to 3%. Okay, so you have to remain confident on your statement. And when they're going to ask you that, can we do invasive things then? Can we do ARM? Can we do the fetal scalp electrodes or the blood sampling? Because you're saying that, the risk is so small. You're going to say not recommended, but can consider if needed. Okay. So full confidence with, you're going to say very small neonatal herpes risk. So with confidence, we're going to give her a trial of vaginal delivery. Then we have a primary infection. So, sorry. So for primary infection, the issue is that you have to classify whether it's before 28 weeks or after 28 weeks. If it's before 28 weeks, then you have to, confirm with suspicion, you have to refer to the genitourinary medicine department. They're going to do a PCR, screen for other STIs, and then, do the contact tracing. The writing is very beautiful, I hope. Okay. So you have two options. You have the therapeutic regime, then you have the suppressive therapy. So for treatment, less than 28 weeks, how are going to treat? 400 milligram, 3 times per day, TDS, for 5 days. This is it. 5 days, 5 fingers on your hand, 5 days. But after that, at 32 weeks, suppressive therapy is going to start. What is suppressive therapy? Same dose till delivery, not for 5 days, till delivery. For 5 days, you have given before 28 weeks when the infection occurred. Now, suppressive therapy starts at 32 weeks, okay? But if there is suspicion of preterm birth, then the suppressive therapy starts earlier at around 22 weeks. And the dose is going to be less. Let's not discuss this. This is, going to confuse you. Simple. We're discussing right now. You understand this? Now, after 28 weeks, there is no different therapies. Okay. After 28 weeks, if it's primary, simple 400 mg TDS until delivery. One regime only. No suppressive and therapeutic regimes are not separate. But in this case, after 28 weeks, the choice of delivery is via cesarean section. Do not deliver vaginally, guys. But there's one more option.